Good morning, everybody. Now we are going to present an IC on phacoemulsification with me. I am Dr. T.P. Lahane from Mumbai, Dr. Agini Parekh, Dr. K.K. Mehta, and Dr. Navneet Tosniwal. So I think we all are doing phacoemulsification. In that, I am going to speak to you on the supra-hard, or you can say the hard cataract. And when you are dealing with hard cataract, what different weapon you should have whenever you are thinking of doing the hard cataract. So that is my topic of presentation today. Normally, I am not having any financial interest in my talk. See, it is like a string. So whenever you are doing a hard cataract, I always say who has done more than 100 cataract, he should go with the slightly, you can say, grade 3 cataract, and then when he has done the 1000 cataract, he should touch the black cataract. So before that, he should not touch the black cataract, and whenever he is doing this, then he will have to think what is important. Important is the capsule. As you know, the capsule is not seen, it is a black in color. The rexis for that glow is not seen. The support, as you know, the sclerosis of the lens happens, also the zonular sclerosis also there. Though you feel that the lens is good, but sometimes zonules are weak because of sclerosis. Then whenever you are doing it, requires a more phaco power, and that damages the endothelium. And then second day, you will have to tell there is a air inside the eye, and so you can't see, you will see after few days. So that you will have to tell the patient every day. Then the trenching is very difficult because you have a hard cataract, and then risk of not only PCR but risk of that nucleus going behind and inviting your colleague retina. Then how do you manage? So whenever you are managing, there should be important steps, that dye-assisted rexis, you will have to go with that. The multi-level hydrodissection, then adequate visco. In between you will have to also inject visco. Then the phacomodulation, whatever is there in the machine, that you can use. And the technique. So the technique which is good in your hand, you must use that. So the dye-assisted rexis and slightly larger rexis. See here so can see the cataract, it is seen brown in color, and so you can't see the capsule. So when you can't see the capsule, then better dye-assisted rexis. Now this dye, once you inject, you will have to wait for 13 to 17 seconds, so that will help you for the, you can say, tear of the capsule. So immediately just you can injecting, you should not go ahead, wait for few seconds, and whenever this is made, so it should be slightly larger rexis, because if it is a smaller rexis and you are making the pieces, the back collapses and it goes behind. So you can see this whenever you are doing the dye-assisted rexis. See here. So you must do it slightly larger rexis in the dye-assisted rexis. Then whenever you are using the cohesive and dispersive, so that is important. These viscoelastic substances are very important whenever you are doing it. Now here you can use the quadrant, visco quadrant. It means every quadrant put visco and then quadrant, put visco and then quadrant. And soft shell, you can also use this soft shell technique. And the phaco power modulation, you will have to take the advantage of the machine and the modulations of the phaco. You can use the quadrant removal by the pulse mode, direct chop, continuous mode with the high vacuum, and trenching by the multi-burst or burst mode. It means if these things are there in the machine, that will be useful. Now see, this is a, you can see the cataract is a black cataract. When you are touching this cataract, see here, I am going in and then I am separating the this piece, and when separating again see properly, there are leathery fibers behind. So you'll have to separate it up to the center. So this leathery fiber is the main key in the nuclear cataract. See these leathery fibers, they are separated up to the center, but in the center they may not be separated. And if those are not separated in the center, then those fibers, they will bring the nucleus tip down. And once that tip goes down, you are removing the other piece. Then that tip is a sharp and then PC get tear. So see here, now again I am making the another pieces here, and after making the two pieces I have made the another piece, and see here the piece what I am taking is a larger one, but gradually you will have to emulsify this piece, and I am using here both. You can see longitudinal and torsional phaco I am using, but this is because of the Centurion machine, but you can also do it with the any other machine. Only thing is you should be well knowing about your machine. See here, only thing is phaco is not you can say fast technique. It is a slow technique. You must go slow, and gradually you can see you grab the pieces, and you will see last piece you will have to be very slow, and after that you can remove the piece. It means the hard cataract, yes, you can remove it. See the, once you see the technique, the other technique I will show you, the direct chop. Always remember, see this, when there is a hard cataract with white appearance inside, then only you go for the direct chop. If it is a black one, don't go for the direct chop, because here fibers will not, can say, help you there, but here you will see the posterior fibers are there but minimum, and because these posterior fibers are minimum, in such situation, see here, I am going here and you can see my chopper, and every piece is separated up to the center. See again going inside, and again I am separating. So whenever you are doing the chop technique, there you will first see patient's lens on the slit lamp, and if there is a some whitish appearance inside, that there you can plan for the you can see the chopping. See here again, see how I am doing. The chop is like this. See here, the two instruments you can see together, and then you chop it. So again the chopper and the tip of the phaco, see here, phaco tip, see here, the two are in the same line here, and then you can make the piece, and when you are making the piece it should go beyond. Now here you can make small pieces also, but I always do the half nucleus, two pieces, so that your half part is done, and after that then I do for the separation in the four pieces. So you can do four pieces or you can do three pieces, and you can remove, so that that will also create a space. But sometimes if you create a space, another half nucleus may trouble you for making the pieces. But yes, it should be inside the capsule, and here you will see again I am making the piece of that, and once that is a, see here, separated, so then I can just remove it. Here you can see the piece is removed, and both cases you have seen the, it was a slightly whitish appearance, and in such cases you can do chop. But if it is a black, you have seen the first phaco, when it is a black, in that, so you can improvise yourself gradually. So don't run for the black cataract. Yes, I can do phaco, so that can trouble you. Now this is the here the hypermature cataract will be covered by Dr. Agini, but what here I am showing you, this is a, you can see the so many dots in the capsule. When you see this fibrous dot in the capsule, it means the capsule is, it means it is a hyper mature cataract. Now here you can't do the rexis because the zonules are weak here because of the hypermaturity, and what will happen with this, everything will come out. What I am doing is I am using the two things. One, I am using the forceps, and one, I am using the scissor. So by using the scissor and forceps, see here, for me such cataract should be operated by SICS. But if you want to go for the phacoemulsification, here you can't do the phaco. So I have brought this in the anterior chamber, and then I am using the scaffold because there is a bag. There is a bag. So I am putting the lens, implanting the lens in the bag, and once I implant that lens in the bag, see here, then I am doing the phacoemulsification. As you know, this is a white cataract, and in the white cataract normally it may be a hypermature, it is a soft cataract. So whenever you are doing this, always better to go for the such type of cataract, you go for the SICS. If not, then you can use the scaffold. The stop and chop or direct chop technique is, you should decide. Effective use of the ultrasound energy and the experience. Experience is very important. Learn from your and your seniors' mistakes, and also the experience. Both things required here, and choose what is effective in your hand. You see the video here, and go and do in your hospital is not good. Your experience, and you must be confident that yes, you can do it, and that time I think you can do it. The such type of heart cataract not difficult. Thank you very much. Ragini, second.
Sir, there is one question.
Yes.
That in the early phases of the practice, in a hard cataract, there is some situation will come where we feel that we have to convert this case to SICS. So, what are the such a situation?
See, I will
because
tell
you are the equally mastery in the SICS. Which are the
I
situations?
will tell you, when you feel that the zonules are weak, or you can say you feel that there is your nucleus is just going down, so it means there may be a small PC tear. Nucleus is not rotating, it means there is a problem in the nucleus. In such situation, instead of forceful rotation, once you rotate it forcefully, that rotate in the vitreous and not in the anterior chamber. So in such situation, it is better to go for the you can say SICS and remove the nucleus, and you put the lens whatever. If there is no PC tear, then go for the one piece lens. PC tear is there, Ragini ithaच आहे. Then you can go for the 3-piece lens. So, but I think the converting is better than just going ahead. If you not convert, then definitely there will be a problem, and that problem throughout this, that patient will be like a thrombosis of the your one vessel, and every time he will be coming, and then that thrombosis gives you ulcer, and once there is ulcer, that ulcer will say everything. इसका मेरा यही ऑपरेशन हुआ था, I can't see. This ulcer will ask other patient, don't come here, I can't see. So it is better to not to create any ulcer, and you just terminate your phaco and go for SICS. SICS also is an excellent procedure. Thank you.
Thank you, sir. Thank you.
Chair, respected Dr. T.P. Lahane, Padma Shri Dr. T.P. Lahane, sir, my friend Dr. Navneet Toshniwal, we've learned, both of us, Navneet and I, have learned a lot from sir. We will be discussing hypermature cataract, multiple ways to tackle. Now, sir has already said that the best way to do such a cataract is SICS. But with the advent of Indian intraocular lenses, which are affordable, and we being in a government college where the patient doesn't have to pay anything else, everybody wants a foldable lens. So, what are the challenges in a hypermature cataract? As we all know, there is no glow. The rhexis extends, as we saw in one of Sir's cases. Posterior capsular rupture is more common. Nucleus drop, endothelial damage because you take more time to do phacoemulsification, and because you may not have a rhexis, there may be a decentered IOL. How do we manage this? So, use of dye. It's very important to use dye, and it makes our life easy. In case of rhexis extension, it can be prevented earlier only in the beginning by using a forceps can opener, but if you break the commitment to the rhexis, you break the commitment to phaco. So having a smaller rhexis is important. In case of posterior capsular rupture, one must learn anterior vitrectomy. All of us must learn. I was late in learning, but you know, it has made my life easier because if you know how to cut the vitreous, if you can do cataract surgery, it is very easy to do anterior automated vitrectomy. And then the choice of IOL changes to have a standby IOL. In case of nucleus drop, VR surgeon referral. The previous session she was saying that don't touch it, just refer to a vitreous surgeon. Endothelial damage can be prevented definitely and should be prevented by using good viscoelastics, because after the surgery you may put in the lens, you may do everything, but because of SKs the patient will not see and it will be an unhappy patient. Decentered IOLs will have to be tackled with later, so one has to be careful for the need of a second surgery. Now this is the first case we'll see where you can see it is a hypermature cataract. There is an ACO, means this was traumatic. The tunnel is a corneal tunnel. A dye-stained rhexis, as you can see, you can start with a needle. If not comfortable, you can use a Utratas forceps. Micro forceps which are used in children are very, very good also. So doing the rhexis, you have to make it a little larger because of that ACO, the anterior capsular opacification. Gentle rhexis, and as you can see over here now, the forceps is being used. So you can use both, but what you have to do is ensure a complete rhexis. So if you feel that the needle is not good enough, come out, put visco and take this Utratas forceps. Gentle rotation, because this step is very, very important. The rhexis is larger than what we wanted, but luckily it is complete. As you can see over here, there is no epinucleus. The nucleus has become vertical, but not to worry, this you have to hold the nucleus. So vertical nucleus, you can do an easy horizontal chop. Important thing is the holding of the nucleus, you are a correct power, the nucleus should not run away, and the chopping. So once you hold the nucleus, there is no trenching, it is a direct chop and making of the pieces, careful management of the nucleus, protecting the endothelium, using the chopper correctly to now cut this nucleus into pieces. And you must see in this video that the phaco probe is exactly at the center. Not running around with a phaco probe and holding the nucleus, as you can see over here, is very, very important. And the dynamics of the phaco will allow the nucleus to remain attached to the phaco probe and with the aspiration, and not to remove it immediately, otherwise there will be a surge. This is the case 2 where you can see very clearly this is a hypermature cataract. A corneal tunnel with correct geometry is very, very important. And as you can see, the first nick will cause release of the milk. So you know that this is a hypermature cataract, and the capsule which is stained again with the dye, a careful capsulorhexis. This step is very, very important. A lot of patients during this step and performing a good rhexis. These capsules are also much more difficult to manage than the other capsules. The escape of the milk again changing to the Utratas forceps. So it's okay. Nobody said that you have to do this, you have to do that. What is important is that it should be perfect. In this hypermature cataract, you can see that the cataract is a very hard brown nuclear cataract. It is rotating because there is no epinucleus buttress. This is a direct Nagahara chop. As you can see, there is no trenching. So here the ultrasound energy has to be very good to hold the nucleus and to chop it directly into two pieces. Now the ultrasound energy has to be good, otherwise the nucleus will be pushed and pulled and there will be zonular dialysis. Again, burying the phaco probe into the nucleus, and as you can see over here, there is excessive rotation of the nucleus. But if you hold the nucleus well with the correct ultrasonic power, it can be divided. Now here, to divide it into multiple pieces using the chopper, and harpooning the nucleus with the correct ultrasonic energy so as to hold it. This is very, very important. Now that this piece is completely separated, that is very important. Unless and until the piece is completely separated, do not do anything, because the pieces will all get entangled into each other. It can be more than 4 pieces because the nucleus is so thick, you may end up with more pieces. That is fine, because you need to have smaller pieces to be able to be emulsified, and then to feed the pieces to the phaco tip, remaining in the center and continuing chopping into small pieces to be able to do phacoemulsification. Here the nucleus is little above the iris plane, so important is use of good viscoelastic. Another patient where you can see a hypermature cataract, making the side ports, doing the dye stain rexes. So this milky fluid, how it can be managed? The cystostome is attached to a syringe. So if you aspirate it, you don't need to come out or use the Simcoe. You can aspirate it with the syringe. That's the tip of the day. And then to do a small rexes, it's very important. In this case, the pupil is small and a larger rexes will definitely run away. You have to know how to hold the rexes at the base and pull circularly, otherwise it will run away. Removing it and then managing the nucleus. This is important that you remain in the center. The nucleus, of course, is mobile because it is only the nucleus, making it slightly vertical and chopping. The correct chop is very, very important in these cases. You need a very good machine to support you, because if you are not supported by a good machine, you may question yourself that you are not a good surgeon, but you are definitely a good surgeon, but you need a very good machine and you need good parameters. So again, though it looks very, very soft, chopping is important here, because you can see there is not even a bit of cortex. Forget the epinucleus. This is such a hypermature cataract that you have no support, you have no epinuclear buttress, and you have to be careful not to cause surge so as to not rupture the PC. So all these cases are very, very important. In a hypermature cataract, as you can see over here, this is again a hypermature cataract, and here you can do trenching. What we saw was the Nagahara's chop, but here the complete dissection of the posterior leathery interdigitating fibers and making complete separation of the pieces. So as you can see, this is a standard chop and stop and chop technique. You can make either 4 pieces or multiple pieces. The nucleus has to rotate in the same plane, and then aspiration of the pieces like any other regular cataract. But the tip here is that the posterior interdigitating fibers should be completely removed. And if you notice, in each and every case, you have to wait for a second before removing the probe, because you don't want any surge. This is another patient of hypermature cataract, but the pupils here are very, very dilated. These are brown cataracts underneath, and you have to be careful to do a good rexis. If you feel that the rexis is extending, you see here the intumescent cataract, you have done nothing but you see the extension of the rexis. So this is the Argentinian flag sign, and you have done nothing. You just made a nick. It is the intumescent cataract because of which all this happened, and you are trying to fashion a rexis. You see the flap motility, which shows that it has not extended into the periphery, and you can continue with phacoemulsification. You have to assess the situation, because if you do not assess the situation, you can see this flap motility, and that ensures you that it is not extended posteriorly. You have to be careful here, because if it has extended posteriorly, which it easily can, and if there is a PC rupture, you can land into more complications. One has to be extremely careful, because the mantra is, if you break the rexes, you break your commitment to phaco. Experience of the surgeon, this is Dr. Lane sir's video, and experience of the surgeon is extremely important in this case. So what is the take-home message? The take-home message is that the dye is extremely important in hypermature cataracts. Your tip should be very sharp. You cannot use a blunt tip. Stop and chop or Nagahara technique. The ultrasound energy that you use is extremely important, so you should know your machine very well, and you have to choose what is effective in your hands. I get scared even to do these cataracts, but I have started doing them. And what is effective in your hands? Phacoemulsification, SICS, conversion, anything, but one must do what is safe for the patient. Thank you so much, friends.
Thank you.
And I thank Sumit for making our lovely presentations today. Thank you so much.
Thank you, Ragini. I think it was an excellent presentation. And now I will invite Dr. Navneet Toshniwal. He is from Solapur, an excellent phaco surgeon and teacher. He has 4 books on phacoemulsification. He is just going to demonstrate us and teach us, if the capsule is running away while you are doing the rexis, how you can bring the capsule inside. So, Dr. Navneet Toshniwal, please.
Good morning, respected Lane sir, Ragini madam. First, I take this chance and opportunity to thanks Dr. Lane sir to incorporate me for this beautiful instruction course. The topic, we have seen the hard cataract, mature cataract. Then the other situation which is commonly occurring is a capsulorhexis runaway. We have to proceed with the phaco. We have to see this presentation with the 3 parts. Why the capsulorhexis is going to be run away in a normal cases also. It may be due to surgeon, it may be due to assistant, it may be due to patient. These 3 situations. Then second, what are the instrumentations needed to manage this runaway capsulorhexis? And still when you manage, you should know the certain principle, how to tackle, how to do the phaco after that. So this is the very slow movement. See, sometimes slow movement also the capsulorhexis run away. So in first book I have written that 3 pages, what should be the speed of capsulorhexis at certain points. And then when this is the direction of capsulorhexis, it is difficult. Now you have to see simple air bubble. One small tiny air bubble, the capsulorhexis run away. So preparation of the capsulorhexis, the anterior chamber should be 100% devoid of any air bubble. You should see the clear-cut visualization, and these are some of the instruments which we are used to 10 years before. The venous scissors, still these are the important. Now if you are having the micro rhexis forceps, micro scissor, that is the best. Sometime now here you can see, suddenly my assistant had pushed the water and patient moved and the capsulorhexis run away. It's a very simple situation, but the capsulorhexis run away, how to proceed? You can take the nick at the other place. Last slide we have seen of the madam that it was just rhexis run away, and how to proceed. So take at the other side and you can proceed. There are certain points when I am doing from a 12 o'clock, if it is 6 o'clock and 12 o'clock, it is difficult. If it is a sideway capsulorhexis run away, you can manage, because the pressure of the phaco tip is not directly on the zonules. That's very important. So site of running away of the capsulorhexis is very important. Here the rhexis run away. I am going no hydro. This is the Toshniwal pre-chopper to divide the nucleus. What is the intention here is that there should not be direct pressure on the zonules. That's the very important for these 2 manipulation. very slow uplifting. As we have seen in Ragini Madam presentation, all the nucleus management in a supracapsular plane. That is very important because bag is weak. So you have to lift the nucleus out of the bag to preserve the bag, not to give pressure on the zonules. That's the main principle here. Then go for the other nuclear half piece and lift it out. These slow movements are very important. Otherwise, also hold and lift of the nucleus should be very slow in a routine practice also. In this specific, there should not be any stretch on bag or zonules. That is the thing we have to keep it in mind. Now, I have just mentioned that microrhexis forceps is important, that we have to use in our day-to-day practice also. We are having the microrhexis forceps. We have started doing, and here overconfidence and maybe the speed. See, that's the sub-incisional running away is very common. What we have to keep it in mind, that formation of the anterior chamber is really good throughout the procedure. If it is getting shallow, you should not be overconfident that, okay, I will manage, because all the time we are in a hurry to do that. And this is the typical point where the surgeon mind plays and the capsular axis run away. Putting the viscoelastics over the flap, not stretching the capsule unnecessarily. These are the very, very important points. This is the micro scissor trying to cut the capsule, because that is the only site from where we can go. This we can do with the venous scissor also. This is very important. Putting the viscoelastics, not giving any stretch, not giving any pressure. We have managed actually you have to do very small tiny rhexis, but I thought that we can manage. And while removing the debulking the pressure in the bag, this is the actually adequate rhexis, but I thought that we will little bit increase. That was my mistake. So although you are having the excellent instrument with your hand and say, otherwise I would have managed with that small rhexis. It was not very small, it was 4 to 4.5. But this is what we think at that time, and suddenly it has run away. Then you have to cut with the micro scissor. These are the very excellent, and again it is a sideway. So you can directly start with the stop and chop technique. Again the division. There is no pressure. Lift it out. Supracapsular plane. This is again I am emphasizing that you should not do many activities in the back, many procedure in the back. Bring it out. And as the sir has mentioned in the hard cataract, role of viscoelastic is very important. Dispersive viscoelastic, if you protect your endothelium, then it will be no damage to the cornea. Coaxial irrigation aspiration I am using. Bimanual is a choice in such situation which maintain the architecture. And before coming out, you can put the viscoelastic. That is another very important. Rhexis run away, but you can see, you can feel that rhexis and all that, so that you can put the whatever the IOL you are having, whatever you have decided. This is the again one question which I have asked to the sir in hard cataract. When you have to shift the case to the SICS, so many times if you are not having the best machines which works nicely with the energy, vacuum and flow rate, no need to do the aggressive things, that you have to remove your ego Just I am doing with the limbal incision many cases of mature cataract, so that I can convert the case very easily, and it is like just a routine SICS. What I have decided before, I thought to do phaco, then I have to convert, and in a very simple way, simple technique, just shift to the SICS and manage the capsule, because this is what we have to keep it in mind. Many doctors I have seen, they are excellent in phaco, but they don't have the great principle of the SICS, but it is a must. SICS is a more important surgery. As the sir has also mentioned, that is important. You cannot leave the case like that and then convert the case, and then you can put the choice of my lens is 3-piece PMMA IOL. That will giving the excellent, there is no pressure on the zonules, it is a more flexible, and this is the way you can manage the things. So capsular axis runaway is the thing can happen with any surgeon. You have to be ready with the instruments and think of any time conversion. That's the final take home message. Thank you for your
Navneet.
patience here.
I think whenever we are doing the rexis, and in that rexis, if we are not complete in the rexis, then first of all we must try for completing the rexis. The shape and size may be vary, so don't go on the, you can say, shape and size every time. It is not possible that it should be a very circular rexis like a femto. So always think it is a manual rexis and not femtorexis. And secondly, if there is the rexis is not happening properly and the matured cataract is there, better to convert. So I think in phaco surgeons, sir, KK sir upar aiye. So phaco surgeons, we are a phaco surgeon, but I think we should not bring ego inside that phaco. So once you bring that ego, that is the problem. So you must drink some water in between when there is such type of thing happens. Your pressure inside the body, hypotension, and then you can think properly and you will not operate further. Otherwise, you will send the nucleus to the another end, that is in the vitreous, and then that other person will tell that patient, नहीं उसने खराब किया है, he has not done good thing. So it is better to avoid that. Thank you.
Thank you, sir.
Good morning, Padma Shri KK Mehta sir. So he is our teacher and guru, and I think he's one of those surgeons today in India at the age of 82 who has a huge OT list today, which include VIPs and ministers. He's a great teacher. And Dr. Lane sir will now be talking on the posterior polar cataract with a posterior capsular defect. Thank you, Navneet. It was a great talk.
Thank you, Ragini. Welcome, Padma Shri KK Mehta sir. He is my guru, my inspiration, and I learned phaco from him because I was doing phaco. On 13th number, I got the PCTR, and I thought I can't do it. He told me, sir, I am coming to your hospital. I will sit in the operation theater, and on that day, 95 June, he was with me and I operated 13 cataract and because phaco, and from that today onward I may be completing 1 lakh phacoemulsification in the next month. It is just because of KK Mehta sir. Thank you, KK Mehta sir. And now I am going to speak to you on the posterior polar cataract. Nowadays this posterior polar cataract number is more because people are using two things. One is they are using the steroids for the body making, and the body making they are also making posterior polar cataract. The second thing, they are using the so many recent technologies in the body making, that is you can say the Ayurvedic drops and so many, and they are again inviting the posterior polar cataract. Another thing is because of the, you can say the allergic conjunctivitis, they are putting the steroids and inviting the posterior polar cataract. So I think this is all invited posterior polar cataract, and this I will deal with few cases of the post-polar cataract. Now here you can see my financial interest that people should pay for the association. Now here, what is difficult? When you are going for the polar cataract, what is difficult? Here there is no grip is not there. Then the chop, if you chop, you will not chop the nucleus, but you will chop the vitreous. So don't chop it. Second thing is surge. You are going to get the surge. So if you are getting anterior chamber shallowing, that time you always feel that there is a PC tear. So anterior chamber is shallow. And then the posterior capsule is unstable because in the center it may be attenuated, that may be a tear, or that may be a thin capsule. So because of that it is an unstable posterior capsule. Now this, what will happen? Now he invites the rupture of the posterior capsule. Sometimes we do everything and then implant the lens with force. But that time capsule is not like a normal capsule, it is a thin capsule and lens goes in the vitreous. Then it is the difficulty in this, frank defect may be there or attenuation may be there. So that you can see, basically see there are some signs, but these signs to be seen by us, not by our assistant doctors. Normally the assistant doctors, they write on your case paper and accordingly you go ahead. Now see, thick central plaque suggests attenuation. Centrally it is thick. But here see thick opacification in the center and which is surrounded by the plaque, thick plaque, white, suggests dehiscence. There is a dehiscence. And you can see peripheral thin opacification. In such cases, capsule is always intact. So you will have to see this thick plaque which is there inside plate or another ring out around it that suggests it there is a dehiscence. Now see here the patient is young, so conceal only patient and also father and mother. It's very important. And another person you will have to conceal is fiancée. It is there. If you will not conceal her, then you had it. So always better to conceal the relatives. Adaptation in the operative technique and also the posterior segment instrumentation, and if in your institute there is a posterior segment surgeon, ask him to remain present. The technique, yes, you can use the good small rexis. In such situation you should not do large because you keep this rexis for the anterior capsular supported lenses. So always do that. Hydrodissection. Now here you can't do the hydrodissection. It should be hydrodelineation. So only hydrodelineation is important, and when you are doing it, low vacuum is important, and aspiration is a dry aspiration. Always use the dry aspiration, that will help you. So now see, this is the soft cataract. I am just like a technique is a flip technique. You can say bowl technique, flip and chip, and no chop aspiration technique. So many techniques you can use in this. And see, this is the case 1 where I have done the flip technique. You can see the central plaque, also the rexis, the posterior, this polar cataract here. And what I have done is a hydrodelineation. You can see the golden ring, and you should rotate that nucleus only where you are not touching the PC at all. And see here, I have separated that. See again, and then see the nucleus has came, and by the flip technique, see here, you can remove the, because it is a very soft nucleus. So the other is if you are not separating it properly, see here, I have made a rexis separated. You can see the golden ring. I am trying to separate, but the nucleus is not getting separated. See here, maybe a hydrodelineation is not proper. So what I am doing is in the periphery, going with the phaco. Only thing is that here you should use very low power and low aspiration. So this is a very soft cataract, and you see the saucer is formed, and now it is rotated. It means still there is a rotation. You should have all type of patience, and once rotated, then you can say just flip it here by the, and I will be, otherwise this is the sharp chopper. but I will advise go for the blunt chopper. That will be more useful than the sharp chopper. The other technique is chip and flip technique. I will show you this, just separating the nucleus. See here, and you can see the golden ring, very soft cataract, very soft cataract because a young patient, and see the nucleus is separated, and I have rotated also, you can see the golden ring, and then in this you can say debulking I have done in the center, and the nucleus, yes, I have removed the nucleus. Again you can see this is the, just I am aspirating because patient is young, see here, just aspiration and the nucleus is removed. So it means, and then I can go for this, the epinucleus, and I am removing the epinucleus also. Here also you can see the separation of the epinucleus, and you have removed the epinucleus. So it means you should go slowly, and when you go slowly, see here, I am doing the rhexis. Normally it is better to stain, but I have not stained it. It is my slightly old video. See here, staining also helps for the tear. So I am doing the rhexis, and see here by the forceps. So regraph, then again see here. So I think the rhexis is done, and the hydrodelineation on the both sides. See here, I am separating it, and once separated, then the nucleus can be aspirated. Now whenever you are doing this, now see the do's imaging, you must do the imaging. Intraoperative parameters very important. Evaluation of the other eye, specifically if that is a pseudophakic, then you can see there is a PC tear, not happened PC tear, whatever has happened in that eye. So that will also guide you. And here hydrodissection, don't do it, but that is in our hand. So when we go in, we do hydrodissection, and that time all the water goes inside the vitreous. Nucleus rotation, always remember this excessive nucleus rotation will trouble you. And phacoeparameters, because that may tear whenever you are removing this nucleus. It is a soft nucleus, so it may go to the posterior capsule. So see, there are so many imagings are there, and this posterior capsular imaging, this is a Mahipal's paper, and in that you can see slit lamp imaging. You can see this in the slit lamp imaging. Then also you can have optical biometer, you can see the optical biometer imaging, or you can go for the femto platform. It means by imaging you can definitely have a image that posterior capsule is weak, there is a dehiscence, or if it is a dehiscence is there, that is definitely seen by the imaging, and accordingly you can plan. Now see, this is another cataract I am doing. See here, the nucleus you can see the separated, and once that is a nucleus is can see the golden ring, and in the golden ring sometimes what happens, so it is not, see, nucleus is not rotating. Till it rotate, you should not go in the center. So in the periphery only, see here, because of that you are see here, and once the nucleus is rotated, you should not rotate it much, only you can just rotate, and then gradually the edge of the nucleus, instead of aspirating from the center, better to aspirate from the edge. Gradually you lift it, and then you can remove the nucleus, and then you can see separation of the epinucleus. Now the take home message is, there are multiple techniques to image, and do what suits you. Always do the imaging. Don't leave your safe zone for phaco. Always do it in the safe zone. Maintain the anterior chamber. It's very, very important. So you can inject visco so many times, but maintain it. And low vacuum and low flow rate is always better. If it is not there, then definitely you have a PC tear. So it is better that always a low vacuum and the you can say low this one flow rate is very important. Thank you very much.
And that really was a wonderful talk, Dr. Lane, because you brought out very clearly what are the big problems which occur, especially with these cataracts and these posterior polar ones, which can really cause a great havoc if it's not properly handled. I must congratulate you on how smoothly you managed to handle it.
Sir is going. Sir is going.
Okay. And now I will invite Padma Shri Dr. K.K. Mehta sir, my guru, who is going to speak to us. Now at 82, he is 82, and still he is operating the governors, chief ministers, ministers, and so many. Okay, and also doing the live demonstration at 82 without a single tremor, no tremor at all. And he can do the live demonstration. Just now he did it in the Bombay Ophthalmic Association in the conference.
And with viral fever that
Yes,
day.
on that day he was running up and down with viral fever. Still he operated. And the K.K. Mehta is going to speak to us on the subluxated. For him, no lens is subluxated, but he is going to speak to us in the subluxated lenses. Let us get the straight. So, by his hand, he can do anything straight. K.K. Mehta, sir.
Thank you very much, Dr. Lane. So sweet of you. I'm going to talk to you today on subluxated IOL, how to set them straight. Subluxated IOLs are always a big headache. How do we handle them? How should we really manage with them? There are, as one would say, there are various ways in which you can fixate a displaced IOL in a bag. The easiest way, of course, is simply to suture the bag to the sclera. Let me show you how it works. This method is something which anybody can do. It works easily, it's a smooth method of handling it, and really it makes life very simple. Now here is a nice, beautiful subluxated cataract. You get up in the morning and look at it and it makes your heart feel happy that you are an ophthalmic surgeon. Aaj maza aayegi. Now what you need to do as far as this is concerned is very simple. The whole idea is that you are going to move that bag with the lens back into its place. Interesting thing about now, this case is of course is a Marfan's, which is a subluxated lens. You normally don't get these huge subluxations for any other reason. You need to do a rhexis. In these sort of cases, the rhexis, the only thing which you can do essentially is a rhexis utilizing a needle, because you have to do a small one. At the same time, you have to be careful that you don't tear the zonular bag at all, because the bag has minimum supports. You do a small little area, you don't need to do a big rhexis at all, because usually these lenses are very soft and you can aspirate them out comfortably easily. You just have to be careful to make sure it doesn't run up to the edge. So try and rotate around the capsular bag in a spiral manner. So you do what we call as a spiral capsulotomy, not a round capsulotomy. First do a little one, then you spiral it around until you get to the size where you want it to go. Having done that, the next thing, of course, is hydrodissection. But in hydrodissection here, before you do that, the most important thing which you need to do is to fixate the bag. Because what you don't want is, when you hydrodissect, the bag swells up, there is pressure on the zonules, and that is usually the time when you tend to drop your lens. So you take your bag and you support it utilizing hooks. There are an option of using capsular hooks. I am not very fond of them. They are long, they tend to hook below, and they tend to cause, and the edges of the rhexis where you have made, they tend to evert a little. So I like using these regular capsular hooks. This is a little hydrodissection, it came out. Now, of course, you do a phacoemulsification with a minimum amount, what we call a slow motion phaco. That means you have a minimum amount of fluid going in, and at the same time, you have the phacoemulsification which is applied is comparatively low. So it settles down and works out smoothly and easily without too much difficulty. And that clears out the central area which you wanted to. A little bit of polish in the edges to remove whatever is the cortical amounts which are left over. Easy way to remove this is to put your II unit there and just to juggle it around. The next step is to use a bag support. So we use this little device where you can feed your lens, feed your loop in, and then just use a capsular ring and put it in. Remember to use a capsular ring so that it goes to the point where support is minimum, so it presses against it and supports it. And then finally take the last end and slip it in. If it goes in perfectly, your bag will not be visible to you, then you know it has gone in well. Now the next step, I want you to be with me for a minute because this is something a little interesting. This is your lens. You take a suture needle, pass it through the opening of the duct which you got it, and then take it and suture it to the end. Pull it out from the tip. So you have sutured one leg onto, as you can see, one leg has been sutured on, and the needle has been pulled out through from the front. So you now got a leg sutured lying inside your bag, inside your inserter. You can use any lens, it doesn't really matter which lens you use because the procedure will work equally well. That is where the suture part goes. Make sure that leg goes out first, flip the other leg out, hold it in place, and now take your needle which you have now pulled out from front. So the needle has come out from front, the thread is tied to the end of the lens which is there. You put your inserter in. Now you take your needle, simply go under the edge of the bag which you have lifted up and go out into the sclera and pull it out. Once you pulled out the needle, the next step is you inject your lens inside from behind, at the same time maintaining a little traction onto the suture in front. So in essence what you have is a suture tied to a loop which has gone below the bag and which you are injecting inside. That's why I call it as the bag to the wall. Now your lens has gone inside, it is settled into place, you flip it into and put it into the capsular bag. Now this is your needle. Now all you have to do is suture your needle onto the needle which you have come out, suture it onto the sclera. Now you have two options. You can suture it, or you don't want, you feel lazy that day on suturing it, you have 2 or 3 passes through the sclera, it works equally well. At this stage, remove your bag support, because now you want to pull the bag on and you want to see how the bag is being pulled. Make sure it lies in below, and now gradually as you pull the suture, you will find that the lens will come and hold up and support it. So in essence, now the lens loops itself are supporting the bag. And as you go on putting traction on the suture, the lens will settle itself in. Take a single bite through, and then after that, you have an option either of putting a suture and letting the edges, turning the edges in so they are no longer will poke out and come forwards, and that is it. So this is a very simple, straightforward method which can be done anytime. All you have to do, as I said, is suture one of the legs on and then pass it through the sclera. Center your lens, move the posterior part. The posterior part is not sutured, the part towards is not sutured. So that is how it works simply. And this is an easy way to execute this thing. And if the bag and the IOL are both displaced, now comes the interesting part. Now what to do? So you remove them and you refix the IOL using Prolene with a modified Kawabara technique. Kawabara was a person who originally started with this technique. It's not my technique. I have only modified it, which I will show you as it is. That's why I call it the Yamane modification of the subluxated bag IOL. Yamane was the one who used this technique of using the openings at the side. Now here you have a bag lens which is moving. As you can notice, the bag, lens, everything is moving. With this you can't suture it. You try suturing it, suture at one end, the other end is going to come out. So the only option right here is really that you need to remove it. You open up a little conjunctiva, lift it, open it up a little. Why do you lift the conjunctiva? Because one of these days you're going to suture it, number one. Number two, you're going to have a lot of fluid going and you don't want conjunctiva ballooning. Easiest ways of preventing a conjunctiva ballooning is to make a little snip in the conjunctiva. Makes life easy. Even when you're doing phaco, if you make a little snip at the base of the phaco, you will never tend to get it. Set your measurement to 3 millimeters, 2.5 millimeters, 3 millimeters at the side in a cross manner. See exactly how I'm doing it. Cross manner. Now the needle will go through the proximity. You put in a little AC maintainer. All these cases, a maintainer is the best idea to handle. Once you've done that, use the needle going through the first point, turn the needle round, and then put it back into the needle. So these are the needle openings which are made. They are like little tunnels, as one would call it. Now you take out that bag complex which is there. At this point, remove the bag finally which comes out. So the lens came out first, bag came out afterwards. Now you cut off the irrigation, which enables it to go back comfortably inside. Insert an air bubble which tells you that everything is fine, there's no vitreous learning there, and put a single cross-stitch suture. That is a safety suture which you need to put. Always put in a safety suture. I mean, you can get away without it, but never take chances. Life is much easier and you live longer. Now you take, just 2 minutes more. Then you take a proline suture needle and you insert the needle, insert the suture into a 27 gauge needle. Why do you do that? Because we are now going to pull out these tractions and you push your needle in from that opening which you have made, that cross opening. So it is, you have made a side opening, so you put it first straight and then horizontally. And you just pull out the suture. The same way you do it at the other end. That makes it very simple to do. And now you hold the proline sutures and pull them out. So you got 2 proline sutures you pulled out, no gymnastics, you haven't shoved instruments inside the eye, you only pushed a needle which you held out. Now you take a rubber bung and use a needle and go through it at the base of the haptic loop junction. Any lens can be utilized, excepting of course a plate haptic, even that can be, but that tends to spiral, which you don't like. Once you push it through, now you use the same suture which you pulled out, you push it through those needles which you have put through that lens. So you've taken a lens, punched a hole in it, those sutures which you got out, you put into that. And you now draw it out again. Once you draw it out, you move the lens forward onto it, so the lens is suspended on those 2 strands of needles which are there. Take them out. The next thing is you flange it. Flanging means you use a cautery and make a little button at the end. This is a low temperature cautery which is available. In case you want to know where it's available from, it's very simple, you get it on Amazon. And you pull the flanges until it locks into place. Pull it to make sure it does not. And then you put your lens inside. No hassles, no difficulties. Please note, there have been no gymnastics. You just peacefully put your lens inside. Just drop it in. Pull your proline sutures on both sides to stabilize your lens. And like you did the flanging on the lens, you now flange the edges. One of the easiest ways of flanging the lenses, first you put it in and then close of your things. Usually a single or a double cross stitch is more than enough to close it. And having done that, now you take the edges of your sutures and bury them, and now you flange those little pieces left over. Hold it and flange it in. You can notice the flanging going on. And that is it. Take your conjunctiva now and put it on top and bend it in a little. You do a little vitrectomy anterior, use a little, and at the same time after doing vitrectomy, you inject in a little steroid to make sure that there is no vitreal strands there. And that is it. And then you pull the conjunctiva over and use a thermal coagulation cautery over it. So your knob is buried inside. You don't need to bury the knob, but the knob is blue color and we don't like watching it. So this is a very simple way in which you can handle these cases. Thank you so much for watching.
Thank you, Dr. K.K. Mehta, sir. I think the surgery, which is very, I think, seen very easy to do with the K.K. Mehta's hand, but it is very difficult whenever the such type of subluxation is there. But yes, as he said that it is reproducible and anybody can do it. Thank you, sir, for guiding us. And now I will invite Dr. Ragini Parekh. She is a professor and head in the Regional Institute at Mumbai in JJ Hospital, and she has performed more than 85,000 surgeries. She is going to speak to us on the small eye, small pupil, and large nucleus. Dr. Ragini Parekh.
Thank you, sir. Thank you for the introduction. So many times we are faced with a small pupil, and what are the causes of a small pupil? It may be a rigid pupil with sclerosis, fixed also. There may be pseudo exfoliation. We get so many patients from the interiors with pseudo exfoliation. What are the problems with a small pupil are that there will be a difficult rhexis, but also a very small rhexis, so nucleus management becomes difficult. Because of the difficulties and the problems associated, there will be a PC tear. More likely, IOL implantation will be difficult in the bag because the pupil is small and you cannot see your bag, and it will be associated with zonular weakness. There are lots of managing strategies for a small pupil. So you can use a stronger mediatric, intracameral adrenaline. Now we have intracameral phenoclane. Viscomediatis, the viscoelastic itself will dilate the pupil to a certain extent. Lots of devices can be used like iris hooks, pupil ring expanders, sphincterotomy we used to do in the olden age when we didn't have so many devices. And you can use associated devices like CTR rings, because with a small pupil and pseudo exfoliation, zonular weakness may be associated. So viscoelastic, you can use a retentive viscoelastic or a soft cell technique. Viscoelastic vault at the end of phacoemulsification. There are so many viscoelastic available. So dispersive and cohesive should be used according to your convenience for the care of the patient, and you have to protect the endothelium, which is very, very important. So these are the various devices: iris hooks, the B-hex pupil expander, the Malugin ring, the Gupta's pupil expansion ring, the expander. So many devices are available in the market. So as you can see, this patient has a very small pupil, and I would like you to notice that with the capsulotome itself, you can gently stretch the pupil to make it a little larger. This is a mature cataract, so dye is used to stain the capsule and to make a rhexis. You notice the small sphincter tears which are already present. Now phacoemulsification, while doing phacoemulsification, the center of the nucleus is the hardest. So please note that this chopper is used to keep the iris away. When do you use devices? People say that you have not used device in this case. But if you are comfortable doing phacoemulsification, protecting the iris, not getting it entangled, remaining in the center of the nucleus, because that is the hardest. Once that divides, the other periphery will divide, and remaining in the center, you can aspirate the nucleus, as you can see right here. So if it can be managed, there is no need to use the device, because any device may affect the shape of the pupil, may cause post operative pupillar inflammation. So as you can see over here, if it is possible to do a complete phacoemulsification remaining in the center, you can use the chopper to see the periphery under the iris if there is any cortex remaining. Excuse me. So Phenocane Plus has turned out to be, oh, baapre. He's okay, thank God for that. So Phenocane Plus is a big boon to us. So when you're using Phenocane Plus, 95% of the pupil dilatation will occur within the first 30 seconds, and we notice a good amount of dilatation. The intraoperative pupil diameter remains stable, which is very, very important, because many a times you have a pupil which has dilated and during the surgery it constricts, and the mean time is for intracameral dilatation is 28.6 seconds versus 20 minutes for topical. Now, as you can see, this is a very clear case where the pupil has not dilated, or it's a very small pupil. Now, what you do is, after making the side ports without injecting the viscoelastic, the Phenocane is used. So you are using Phenocane. We have been using Phenocane Plus for a very long time. It is safe intracamerally. It does not cause any infection or inflammation. And as you can see, this is a real-time video where the pupil does dilate. Sir, the pupil dilates well, and you can see the dilatation. It would have been so difficult to do this surgery with that small pupil, and the best thing is that this will remain. Now, after that, you can increase the mydriasis with viscoelastic. So the Phenocane and the viscoelastic has made our life so much easier in this patient. It is almost more than 50% dilated, which is good enough to do a very good phacoemulsification in this patient with a mature cataract. Now, if you see that it is not only the Phenocane or the small pupil here, the mature cataract, while doing phacoemulsification, there is a PC tear, and you must notice this PC tear because the piece which was there is not coming. There is vitreous there. So this is a video which was meant to be shown for the pupillary dilatation, but one must notice that there is a PC tear. There is a scaffold technique which is being used. The IOL is used to support the vitreous or the posterior capsule. Phacoemulsification is being done so that these nucleus pieces do not go behind, and then you can do a good phacoemulsification. Now, the purpose of showing this video was, in spite of the fact that a complication occurred in this patient and the vitrectomy was done, a scaffold was done, the pupil remained dilated till the whole surgery was over. So even in case of complications, it was a big support. So that was the main aim to show this video. If you have so many small pupils, definitely in case of these complicated cataract with posterior synechiae, we do a lot of these patients because we have done the largest amount of leprosy patients in the world at Baba Amte's ashram. So this is Dr. Lane sir's video because he has done the largest amount of patients. So first of all, to break the synechiae, to do the rexes within the visible area, and important thing is that you have to do the first division correctly. If your first division goes well, then it is you are halfway through a successful phaco. Remaining in the center of the pupil is important. No devices were necessary. The pupil, the cataract, the center of the cataract is hard. Once it divides, the periphery divides. Only thing is, here you have to be careful about the iris management because the iris is floppy. It is an ill iris because it has iridocyclitis and synechiae. So you must not let it get engulfed in the phaco tip. The chopper is a very important device to keep the iris away and to do a good phacoemulsification in these type of cases. So what is the conclusion? That Viscoelastic use, because this is not a normal eye, you will be doing extra manipulation. So protecting the endothelium. When I was learning phaco, Lane sir always taught me that treat the cornea like God. You cannot replace the cornea. If you have a vitreous loss, you can manage it. You will put an IOL. You have to manage the macular edema, but the cornea is irreplaceable. Availability of effective intracameral mediatrix and anesthetic agents reduce the need of topical preparations. They may not reduce the need of topical preparations, but if does not dilate well, definitely, as you saw, that you have great support intraoperatively. And the lag time between the patient preparation and surgery should be minimal so that the pupil does not constrict. So you must dilate the patient only few minutes before surgery, and you must use flurbiprofen or something to support the phenylephrine so that the dilatation is maintained. That is very, very important. Thank you. Once again, these wonderful videos are Lahane sir's and Sumit's slides, and the presentations that he made for us helped us in making this lovely presentation. Thank you all for being here, and thank you, sir, for giving me this opportunity. I think this is another video, but we can see this video, sir, if there is time.
Yes, yes, yes.
So as you can see again, this is a complicated patient with a posterior synechiae and a festoon pupil. It is a mature cataract and the dye has been used to stain it. So the first stage is to open up the synechiae. Once the synechiae are broken, then the pupil becomes very big, as you can see. So the pupil becomes nice and big and manageable. So that is the first step in opening up the synechiae and then making a rhexis. One has to be careful. A Utratus forceps is used to make this rhexis. There is not only the capsule, but there is a membrane. That is why this membrane which is there has to be peeled off. So once the membrane is peeled off, then the pupil will open up even more. So the membrane is peeled off. And then you can do the phacoemulsification. The pupil is large enough, the patient is young, so the cataract is very, very soft. The iris has to be carefully managed, and we need not need a second instrument to do the phacoemulsification in this patient. So there is no need to be scared of patients once you know the correct technique which needs to be applied. Thank you, friends, for the opportunity. And I think Dr. Harbanslal sir is here, so congratulate him on becoming the president of AIOS. And I think we should all concur with him that Lalit Verma sir, whose heart and soul is with AIOS for the last 25 years, should be the executive president of AIOS. I thank you, friends, and I thank my teacher, Padma Shri Dr. Lahane sir, Keki Mehta, and Navneet for this wonderful session. Thank you.
Thank you, Ragini. I think we have got 5 more minutes. If anyone want to ask any questions, we can answer it. Or otherwise, I will ask the panelist, Navneet, when there is a capsule is, you can say, living away, or you can say it is very running away. So what are the important steps you will tell us?
Yeah, the most important is the in hydro, means hydro dissection to be avoided to increase the rhexis. Otherwise, if you are having the instrument like pre-chopper, division, equal pressure on the both halves of the nucleus, so no pressure on the zonules, and then slowly lifting of the nucleus out. There should not be a very fast movement to save the back. These are the important tips, sir.
Very true. Thank you. Ragini, when you are doing the, can say, small pupil, so what one tip you will tell? Small pupil, phaco.
Small pupil phacoemulsification, one has to be very careful in protecting the iris, not to get it chafed, protect the endothelium, use viscoelastic, and it can be done without using any devices. Before using any device, one must be careful to learn the use of device properly, otherwise you will get an irregular torn pupil with severe postoperative inflammation.
What the Dr. Ragini had shown is the excellent way of using the chopper to dilate means to separate, keep the iris away during the procedure, and that makes the really new innovation. I think we can go for such a type of instrument that it work like chopper, and just to keep the iris away and manage the nucleus management.
So that is something that Sir does very often, because as I said that he does a lot of leprosy patients, and if you use devices to separate the iris stays in leprosy patient. Even if you handle it slightly, the patient gets aniridia. So this was devised by Dr. Lahane sir, using the chopper to keep the iris away without using any device.
Thank you very much, Dr. Navneet, Dr. Agini, and K.K. Mehta sir just left. And thank you each and everyone who attended this. Thank you very much. Thank you.